My name is David Choi. I'm a clinical pharmacy specialist and associate director at the University of Chicago Medicine Inflammatory Bowel Disease Center. And I'm excited today to be talking to you about IBD specialty pharmacist role, authorization process, and recommendations for community practices and rural areas as well. So here are my disclosures. So before getting started, I want to start off with a patient case. And this is just to really kind of be able to follow along in terms of tips and tricks in terms of how you get access to therapies and getting the patients the care that they need. So here we have a 30-year-old patient with Crohn's disease that's complicated with severe Crohn's disease, complicated by ileal stricture, referred to your center for further evaluation. Their current therapy is infliximab, in which through therapeutic drug monitoring, patient was identified to be a primary non-responder, meaning they don't respond to TNF alpha as a whole, so patient has failed the TNF alpha class. Their prior therapies are vedolizumab, in which patient was also a primary non-responder, as well as azathioprine, in which the patient developed pancreatitis. After shared decision making, the plan was to start an interleukin 23 agent, IV loading dose, followed by the subcutaneous maintenance dose as well. So hopefully throughout this process and kind of throughout the various speakers, you kind of talked about how these advanced IBD therapies have truly revolutionized our ability to treat our patients with inflammatory bowel disease. So why is this so difficult for getting the patients on the therapies that they need? And really the answer is due to cost. These are very, very expensive medications. So this is not an extensive list. Just kind of showcases previous therapies that have been available, the cost per dose or per month, and just how these costs have changed over time. So not only are these therapies very expensive to begin with, you can kind of see how over the time the cost of these medications had really grown significantly during this time. In particular, because of that, the insurance companies have developed cost containment mechanisms to help try to maintain cost, which makes sense. We're a society of limited resources. We don't have unlimited resources to treat every single patient with every single medication, and that cost effectiveness is an important consideration. Although in theory that is beneficial with the prior authorization appeals process, we know though that the current process is broken. And really it's made it very difficult and challenging to get our patients on the therapies that they need, and ultimately has increased the administrative burden as well. So hopefully through today's presentation, we can kind of give you those tips and tricks. How do you best navigate patients throughout this process and kind of things like that? So going back to our patient case, once again, after shared decision making, the plan was to start the interleukin 23 agent of IV loading dose followed by a subcutaneous maintenance dose. So what can you do to better prepare patients for this? So what can you do before you start to help plan for these advanced IV therapies to help streamlining the process? So the most important thing that you can do during that clinic visit, during the telemedicine encounter or anything like that is ensuring you have the updated insurance card information. So, do you have the updated insurance card? And this is important because you don't want to be in a situation where you thought you had the updated insurance card, prior authorizations were sent. 2 weeks later, you're checking in. Turns out the patient had different insurance completely, so you have to restart that process all over again. You want to make sure that baseline labs are done prior to starting too. The main reason for it is by the time you get approval, hopefully the baseline labs have resulted and patients are good to go. I think you want to try and avoid the times where you're not able to start because you're still waiting for the baseline labs and then you're trying to track down the patient, asking them to go to the lab, kind of things like that. So just get that done during the initial appointment. One of the most important steps is setting reasonable expectations for the patient and family. The main reason for it is one, you want to make sure that they're not sending excess messages, like let's say within an hour the next day about, hey, any updates with the plan. Setting these expectations can be very helpful to help maybe minimize some messages that your clinic may receive about the process. So, what those expectations entail is talking about the prior authorization process. So, talking about what step therapy may mean, meaning that the insurance companies may require patients try certain therapies before moving on, and really setting reasonable expectation of how long it should take to get these. At University of Chicago, we asked 14 days, so 2 weeks to get initial prior authorization requests. So, kind of setting that is going to be very important. I think something else to really talk about as well is just talking about what specialty pharmacies are. They're not going to be able to go to their local Walgreens or CVS to pick up these medications, that it really does come from specialty pharmacies, and the majority of the time, those are mandated by the insurance company. Ultimately, I think something that's helpful too is having a backup plan. So during that visit, talking about, well, this would be our preferred therapy, but if insurance denies it, this is the alternative is actually okay with us as well. And I think that's really important because once you get the PA denial or something, it's easy to help pivot rather than having to wait for the patient to come back to a clinic visit, or maybe as a provider having to call the patient to rediscuss a newer therapy too. So it just once again allows you to plan for that at baseline so that you make the process seamless to try and really expedite the process of getting this approved as well. So, with that being said, I wanted to go over an example of the approval process and what that looks like. So, through this process, I want to talk about the two different benefits that you may see. So, the first one is an intravenous loading dose, as well as any kind of self administered medication, which is subcutaneous self injection, oral medications, kind of things like that. So, anything that's administered in a healthcare setting generally falls under a medical benefit, while those that are administered by the patient at home is a pharmacy benefit. And those are two separate insurance processes that need to go. So, in particular, for this medication, interleukin 23, that has an IV loading dose, as well as a subcutaneous maintenance dose, you need to get both approved. So, you need to get the infusion approval as well as the specialty pharmacy or pharmacy approval as well. The majority of the time, these two do not talk to each other. So it's possible that the medical benefit approves it, but the pharmacy denies it, or vice versa. The pharmacy benefit approves it, but the medical side doesn't. So as a result, it's going to be very important in these situations that someone is keeping track of both in terms of a transitions of care standpoint. So at University of Chicago, we have a dedicated infusion team that work on the referrals process. And then for the specialty pharmacy side, we have a whole specialty pharmacy team here that's dedicated to kind of navigating patients throughout this process. So how that looks at University of Chicago is that when the decision is made to start a certain therapy, a referral is placed. So depending on the people on this call, I think it's just important to really think about what are ways to streamline communication, ways to streamline who's responsible for what process and kind of things like that. So here, the provider team and the nursing team will place the referral, and that's how our patients are, or how our team is notified that we're going to be starting this therapy. The thing that I tell our team, if a referral is in place, you didn't tell us you want to start it. You could literally look at me in the face and say you want to start it, but if you didn't place a referral, you never told me that you wanted to get it started. So this process is just something to think about. So once again, thinking back to your offices and your practice sites, think about different strategies or ways to make it very clear. So here, from an accountability standpoint, it becomes really easy for the team to know, well, when was the initial request made? Kind of things like that. Was it properly communicated? So just kind of think about that in your current practices. So at that point, I want to go over the next step. So once the referral is placed, we then do a benefits investigation. So this comes into a centralized queue to notify the pharmacy team about the request, and we're essentially looking for that active insurance. So earlier on, we talked about one of the best practices is during the initial visit, make sure you have updated insurance information. There are specific things we're looking for. So I'm not sure how many individuals in this call are familiar with what the difference between medical benefits and pharmacy benefits looks like on an insurance card. But generally, the medical benefit, I think, is what tends to be scanned in for visit because that's how the billing works. So, medical side, you probably have it. But from a pharmacy benefit standpoint, there are specific numbers and letters we're looking for. So, we're looking for the RX BIN, RX PCN, RX group. If that's missing from the insurance card, that means they probably have a separate card for their pharmacy insurance information. So it's just really important. Once again, you want to get the medical insurance as well as the pharmacy insurance as well at all times. Make sure that those are up to date. At that point, one of our technicians will run a test claim to see if a prior authorization is needed. And if a prior authorization is needed, we will then start the process. So visually, how this looks is once again the referral is placed, the insurance benefit investigation takes place. 95% of the time for advanced IBD therapies, a prior authorization will be required. So at that point, our pharmacy team will take over the prior authorization process, but the process will stand true for any clinic, any personnel that's kind of assisting with it. So when we think about the prior authorization process, the first step is submitting the prior authorization. There's many different ways of doing it. You could do it via fax, telephone, but in my opinion, electronic prior authorizations are the way to go. So if your current clinic is not utilizing electronic prior authorizations, we definitely recommend you really consider that. There's many benefits of it. One, it gives you real-time updates of approvals, denials, kind of things like that. And then later on, when you're going to reauthorize or renew the prior authorization, it gets really easy to find an old one and reactivate it or renew it and then submitting a follow-up prior authorization to. So during that process, there's a few things you want to include. So always attach a clinical chart note, and these chart notes can absolutely make or break these prior authorizations. These chart notes should really have some key aspects to it to really help streamline the approach. If your clinic utilizes MAs, nurses, or pharmacy team that maybe helps with these, your notes can be absolutely key to ensuring all the information is there. So what I mean by that is at University of Chicago, our providers in the assessment plan have two sections. One is about the IBD, just history itself, and then they have a specific separate section for IBD therapy, which summarizes what past medications have patients tried and failed, what happened, how long were they on it, what was the next medication they were on. That really helps us once again paint the picture for the insurance company, but make sure on the pharmacy end that we know what therapies patient has tried and failed. For instances that patients need a specific therapy, in the assessment plan, please include the comments and patient specific notes. So, for example, if a patient has needle phobia, if the patient has a difficult time with infusion access, things like that, really important to highlight those because those are the key areas that help us make the case of why patients need that therapy. If at any point throughout this process you get the approval, you have access to medication and you can move on to affordability, which I'll be talking about in a little bit later. But what do you do in the cases where it gets denied? So before I do that, I do want to jump in to just show you an example of what the electronic prior authorization process looks like. So for us, we utilize Cover My Meds. This is completely free. So it's a free system to use that allows you to electronically submit prior authorizations. The majority of plans are on here, but there may be one-off cases where they're not. So unfortunately, you would have to revert back to faxes or separate electronic prior authorization programs, phones, kind of things like that. But here you'll see on Cover My Meds how you will go ahead, input the patient information, so patient's name, date of birth, gender, their ID number, kind of things like that. From there, it'll populate specific things that'll pop up. So what medication you're kind of requesting and things like that. But really from here, what's important to populate are the questions. So these are the questions that pop up when we submit a prior authorization to get access. A lot of times, though, sometimes these questions are based off logic. So if you answer a question a certain way, it doesn't necessarily matter what the medical justification is, you may get an automatic denial. So, in particular, if they ask, has the patient tried and failed this agent? That may automatically make it a denial if the patient hasn't. So, that's just something to kind of keep in mind is once again, although your chart notes are absolutely important and can make or break a prior authorization, there are times though that it doesn't matter once again what the request is. If the answer is answered a certain way, may lead to an automatic denial. So, going back to our patient, the plan once again was to start the interleukin 23 IV loading dose followed by the subcutaneous maintenance dose. It's been a few days since the patient has been seen in clinic. The IV loading dose is still pending review with the insurance, and the subcutaneous maintenance dose was denied. The denial reason was that the patient has no documented trial and failure to adalimumab. So, what do you do in the cases that the prior authorization is denied? So, once the prior authorization is denied, we have something called the appeals process. So, the appeals process is something that we have to really have insurance companies reconsider the medical necessity and why patients need a certain therapy. The first level appeal, there may be two different types available. The first one is something called a peer to peer request. That's where you speak with the medical reviewer directly and kind of talk about the medical necessity. In my opinion, peer-to-peer seemed to be losing its power in terms of being able to overturn decisions. I think more and more what we're starting to hear are the medical reviewers saying, "Hey, I'm with you," or "I understand, but this is outside of my hands. All I can do is collect this information, and then the insurance will make the ultimate determination." So, because of that, we have been relying more on letters of medical necessity to appeal this process. So, when we think about it, the appeals that are available is generally a first level appeal, If that gets denied, you get a second level appeal. If that gets denied, a external review request. The external review request that I'll be going in a little bit more detail later on as well is where you ask an outside organization to reevaluate the medical necessity in this case and really kind of making the case from that standpoint. So during this process, you want to exhaust every level of appeal available, especially if a patient needs the therapy that they need. You want to make sure that we're advocating for patients and exhausting the every levels of appeal available. It is important once again to set that reasonable expectation with patients that really the appeals process can take 2 to 4 weeks for that to get reviewed by the insurance company. So it won't be the next day per se. Something that's very, very important, and I want to just showcase to everybody on this meeting as well, is to think about the patient assistance programs or bridge programs that may be available for commercially insured patients that allows you to start therapy while you're appealing this program. So a lot of the newer therapies that have come to market have these interim bridge programs available for commercially insured patients to getting them on therapy while you're appealing this process. A lot of times, all you need to do is get one PA denial to get them started, and then you just need an additional appeal denial for them to fully qualify. And they may qualify anywhere from 1 to 3 years, just depending on the manufacturer and the program. One of the other things that's very important as well is having these appeal packets or things that automate the process. So don't reinvent the wheel with every single appeal. Just have things pre-built that makes it really easy. Pre-populated letters of medical necessity templates. You just have to copy and paste patient's name, date of birth, and maybe just some of their history in there. That makes it easy. So what are some of the things that you want to include in your appeals? So, one, you always want to include a copy of the denial letter. And from the denial letter, they will specifically explain why they denied it on there. In my mind, you should play a game of chess with this, where the game is to get checkmate. So, the purpose of the denial is you want to counter every point and potentially stop any future considerations of why they may deny it. And you do that through the letter of medical necessity. So, in a letter of medical necessity, you're going to have the past medical history. What patients tried and failed? Why did they fail it? What is the rationale of the requested regimen, including dose? What is the summary of supporting evidence that really makes this case? You want to include all the literature, abstracts, articles that once again highlight the need and that this is an evidence based request. The chart note, any recent labs, any objective evidence to disease activity. So we're sending over C reactive protein, fecal calprotectin, colonoscopy results, imaging, as well as intestinal ultrasound is something we have been appealing with successfully here. You also want to include your direct contact information because sometimes the medical reviewer wants to call just to clarify something in the letter. So just making sure you're available. Ultimately, through this process, at University of Chicago, we have a high success rate of greater than 97%. It can take time and there may be a delay, and you may need to go through several levels of appeal. But in the cases where it's absolutely needed for your patient, it's about being assertive, being persistent about getting patients the medication that they need. So going back to our patient. So it's been 2 weeks now since the initial visit. The IV loading dose is approved. The subcutaneous maintenance dose, the appeal was denied. The denial reason is a neurologist reviewed the appeal and upheld the decision that the patient must try and fail adalimumab. Well, when the original PA was denied, we appealed it because once again, patient was a primary non-responder to TNF alpha. We knew that through the therapeutic drug monitoring of infliximab, that patient failed the class of TNF alpha. Okay, so maybe that wasn't clear in the appeal. We'll readjust the language, kind of making sure that we show them adalimumab is not appropriate because the patient has tried and failed TNF alpha and is not a responder of this class. So we submitted a second level appeal. The second level appeal was denied. The denial reason a cardiologist has now reviewed the appeal and upheld the decision, stating that patient must try and fail adalimumab. Okay. So at this point, clearly, they kind of missed the point of what we are trying to make about primary non-responders and TNF alpha and why we need this agent. So what that means is we're going to take this to the external review request. So that external review request is once again where it's outside, technically it's supposed to be outside of the insurance company. It's an independent reviewing organization that will review the need, the necessity of these therapies and kind of things like that. For purposes of today's presentation, the external review was submitted and denied. So 45 days later, after the initiation of the request from clinic visit, we find out the patient has been denied. So, what do we do in the cases that you are not able to obtain insurance approval? So, in the cases that you don't get insurance approval, patients are uninsured or underinsured, or patients are unable to afford the cost of the medications, it's very important that you always evaluate patients for manufacturer patient assistance program or for commercial insured patients, the bridge program as well. Once again, through these, generally patients, once approved, they'll be getting it completely for free. So these are going to be no cost to the patient. For the patient assistance programs, patient will need to qualify based off household size and income. So on the next slide, I'll be going into more information about that. But once patients are approved, they're approved. You can do the New Start education. These are the ace in the back pocket for us, and every single patient that we cannot get approval for, we will always explore these as last line options to gain the therapies that they need. So let's delve a little bit more into what are these patient support programs. So there's two that I really think about. The first one is the Bridge program, which once again are for commercial insurance only. So no Medicare, no Medicaid, no TRICARE, just commercial insurance patients only. And is designed for coverage when there are insurance denials. You may need an initial PA and an appeal denial. Some may require a second level appeal denial. So the caveats of the program depends on each drug, but generally a PA and appeal denial is sufficient. And approval for this is 1 to 3 years. Depending on the manufacturer, they may ask you to resubmit every 6 months or something just to see if you could get the patient. But for 1 to 3 years, depending on the program, they're guaranteed to get it completely for free through the drug company. One thing I do want to note is sometimes though, if the medication is fully excluded, so it's excluded or all specialty medications and infusions are excluded, they may not qualify for the bridge program. So that one is a caveat I want to throw out there too. The patient assistance program is once again for uninsured patients, Medicare patients, Medicaid, TRICARE, or some commercial insurance patients as well. They need to qualify based off a household size and an income cutoff, as well as residency status, depending on each program. But as if a patient qualifies, they generally can get it for free. The income can sometimes be an issue, and each manufacturer has different cutoff for the income. So if this is something you're looking for, just always important to know what is the household size as well as income cutoff, and then screen your patients from that standpoint. So I know that there are a lot of delays kind of related, associated with this. So I want to talk about the pitfalls. So avoid the pitfalls, use all available resources available. Depending on your center, depending on kind of what access to therapies and kind of things that you have, use all available resources. Is there a specialty pharmacy you can partner with? Is there an infusion center you can partner with that can take that prior authorization burden off of you and your clinic and maybe kind of help with that process? Manufacturer programs, grants, and foundations, kind of things like that. So for those in the community or in the rural areas, really kind of work on, is there potential pharmacies you can collaborate with, infusion centers you can collaborate with as well, just to make sure that that's kind of there. So I wanted to end by going over in kind of a publication we had looking at the delays in therapy associated with current prior authorization process for the treatment of inflammatory bowel disease. So these ones, what we found was 95% of medications required prior authorization. The initial turnaround time for the prior authorization was 11 days. First level appeal was about 1 month. Second level appeal was 2 months from the initial request, and the external review was anywhere from 2 to 3 months that it took around there. We did have a high rate of approval when utilizing a health system specialty pharmacy of 97%, and insurers appear to utilize the FDA labeled indication and dosing too strictly, which impacts care. In particular, the main takeaway that we had here was when we looked at the factors that impact insurance approvals, what we found was Crohn's disease patients seem to have a higher rate of approval. We're not sure if this is just due to the perceived complicated nature of Crohn's disease, where they see perianal disease, fistulas, strictures, kind of things like that. But the FDA approval, as well as dose escalation, so non FDA approved indications and off label dosing, were huge impacts to getting these medications approved. So there are new barriers and challenges that we're encountering. I could probably spend another 30 minutes just talking about these, but there are copay accumulators, copay maximizers, alternate funding plans that have truly made it very difficult for us to getting access to therapy, because not any it's no longer about access to therapy, where in the past it used to be that little small square on the left that was the PBM approval process. Now there's a whole slew of affordability issues that make it very difficult for us to get our patients the therapies that they need. So with that being said, once again, 95% of advanced IBD therapies require prior authorization. Persistence is key. Streamline the process with pre-made appeal packets. Have various aspects where it's clear communication, clear roles of who's responsible for what in that process. Use all resources available. So can you partner with a local specialty pharmacy, an infusion center, utilizing the patient support programs as much as you can, just to kind of help navigate patients through that process. So with that, that's all I had, and I wanted to see if anyone has any questions or any considerations.